Kentucky Health addresses the healthcare concerns of all residents of Kentucky and surrounding states. It was created by Dr. Wayne Tuckson, a colorectal surgeon practicing in Louisville. Here is your host, Dr. Wayne Tuckson.
Hi, and welcome to this segment of Kentucky Health. Today we want to talk about a disease that you may or may not have heard much about. It's called ovarian cancer. It's not one of the most common cancers, but still it occurs fairly frequently in women. It's one of the diseases we talk about disorders of the female reproductive tract. As I said in the beginning, it is a fairly nonspecific in its symptoms, yet the outcome can be bad because the disease is oftentimes diagnosed at a late stage. There have been efforts done by several different centers, including our own here at the University of Kentucky, in trying to find ways of making the diagnosis earlier, so it's like we can with most cancers. If you can find it early, we can cure the person of their disease. With me today is Dr. Jack Van Nagell. Hope I've gotten that correct.
Yes, absolutely
didn't
right.
Make the family wrong. Who is the chief of the Division of Gynecological Oncology at the University of Kentucky School of Medicine at the Marquette Hospital, or Cancer Center, should I say.
Marquette Cancer Center, yep.
Jack, we'll call you Jack, if
Yes.
that's okay. Tell me, when we talk about gynecologic cancers, what are we really talking about?
Well, Wayne, we're really talking about cancers in the female pelvis. As we're talking about today, ovarian cancer. Other ones are cervical cancer, which we know is detected with Pap smear screening, and uterine cancer. And uterine cancer, we often can diagnose early because of the symptoms it produces, abnormal uterine bleeding, particularly in our postmenopausal ladies. So we can diagnose those cancers early. Cervical cancer through Pap smear screening, and uterine cancer because it produces symptoms early. But ovarian cancer is a different story. Ovarian cancer produces no specific early symptoms. I mean, there have been a number of studies in the last several years that have emphasized that ovarian cancer patients may have certain symptoms more commonly than those who don't have the disease, like bloating, or a feeling of pelvic pressure, or pelvic pain. However, these are nonspecific. So if you had, say, 100 women that had these, say, bloating or pelvic discomfort, whatever, most of them would not have ovarian cancer. I mean, so they're very nonspecific, and so consequently most women ignore them, and consequently most women present with advanced ovarian cancer because, as we can see, the normal ovary is very small. It's only about 1.5 inches by 1 inch or so in postmenopausal women. You can't feel a normal ovary in many patients at the time of an annual examination, much less detect a very small abnormality on the surface of the ovary. In fact, we like to say that a woman is protected in many aspects of pelvic cancer by having an annual pelvic examination with Pap smear, but this does not apply to ovarian cancer because of just what we've said.
Now, where are, since we see that picture of the ovaries, where are they really located? Are they in the pelvis, or are they really in the abdominal cavity?
No, they're in the pelvis, deep in the pelvis, and as we know, the ovaries produce ova in premenopausal
So it's eggs.
and they are picked up by the fallopian tube, and actually fertilization occurs in the fallopian tube, and then the fertilized ovum implants in the uterus, and then we have a pregnancy. So it's really deep in the pelvis.
Now, there are hormones that are produced by the ovaries too, right?
Yes, absolutely. The ovary produces estrogen and progesterone, and when a woman goes through menopause, she stops producing both progesterone and estrogen. And then estrogen is produced by the conversion of a hormone androstenedione produced in the adrenals, and then taken to the periphery, the peripheral fatty tissue, and converted to estrone. So still, a postmenopausal woman can have high levels of estrone, but she is not cyclically producing progesterone. So therefore, it's an estrogen milieu, and then there's estrogen receptors in the endometrium, or the lining of the uterus, which respond to that estrogen. And particularly in overweight women that have a lot of subcutaneous tissue, there's a lot of estrogen, and those women are at high risk to get endometrial cancer.
Now, on this next slide, you're talking about how common the disease is.
Yes.
Now, I can remember several people in my family who've had ovarian cancer, well, not my immediate family, but it's still, but yet you don't see that many people with this problem.
Well, that's right. Now, ovarian cancer, the lifetime risk of ovarian cancer in the average person in America is about 1.2%, the lifetime risk of getting it. Now, if you have a primary relative, like your mother, your aunt, grandmother, that has ovarian cancer, then the incidence is higher, maybe as much as 5% lifetime risk. If you have more than one primary degree relative, then may go up as high as 7%. And then there's some rarer situations of familial ovarian cancers, patients that have an abnormality in the BRCA1 or BRCA2 regions of the genome. These families are rather rare occurrences. But overall, in this country, ovarian cancer occurs about 25,000 new cases a year, about 13,000 deaths. It's the 5th leading cause of cancer mortality in women. So even though it's not that common, it's very lethal.
Do you find it any difference in racial or ethnic groups?
Not really. I think that ovarian cancer is a disease of well-educated people, upper socioeconomic people, many of the leaders of the community. It's not a disease of the underserved medically, like, say, cervical cancer is.
Is that because the diagnosis isn't made, or?
It's a combination of things, really. I think, if you're medically underserved and the HPV virus, which causes cervical cancer, is prevalent, and you don't get your pap smear, then you may get cervical cancer. But in ovarian cancer, it as you have pointed out, it is very difficult to detect in the absence, say, of screening, even with screening. And even though the patient may be very well educated, go for annual pap smear and annual pelvic examination, they still, because they're not expecting any specific symptoms or whatsoever, they still present with advanced disease. So it's really not something that you can pinpoint in, say, a medically underserved group of people.
Unlike in HPV, where you talked about that relationship in cervical cancer, and I guess with uterine cancer, where lack of pregnancies or unopposed estrogen may be a cause.
That's right.
Are there any things that, other than genetics, that may predispose a person to development of ovarian cancer?
Well, we think that people that are not pregnant and they're so-called incessant ovulation. Their ovaries are never at rest, so to speak. And so every month they're ovulating, that whole process of repairing the surface of the ovary. And then if you have some abnormal type of influences in that process, then ovarian cancer can occur. So the patient is at highest risk who has not achieved pregnancy, has not taken birth control pills, because in pregnancy, as we know, ovulation stops, it's rested. So the incessant ovulation is the problem.
Now, in this next slide, I guess this is one showing a normal ovary and a cancer.
That's right.
So,
And we can see on the right that that's a fairly good size ovarian tumor there. And the reason that a woman really doesn't know that they have this significant size tumor is because the pelvis is a big place. After all, a pregnancy is in the pelvis.
True.
And women can have 8 or 9 pound babies, and so it takes something big before symptoms occur. And an ovarian tumor can grow quite large before producing any symptoms.
So now you've come up with a technique, or you're part of the development of a technique for doing screening. But what does screening really mean?
Well, screening means that when you take a group of people that are totally normal, they don't know that anything is wrong whatsoever, and you apply a test or tests to that group of people in order to detect a specific disease earlier. And that's what screening is. You can't, if a person, for example, comes in and has a feeling of pelvic fullness or pain up front, she's not eligible for our screening.
Not screening then,
So I mean, in order to be, the true meaning of screening is you have to be entirely normal as far as you're concerned.
Okay, on this slide, you look like you're going from normal to disease. Is it always this nice steady progression?
Well, the thing, what we know, and Wayne, you know as well, in colorectal cancers, some cancers take longer than others to advance, and some of the recent literature would suggest there are 2 types of ovarian cancer. Maybe there's a kind which is slower, and you have a longer window to pick up this type of ovarian cancer before it advances. And there's some another type 2 ovarian cancer, which is a sort of a poorly differentiated cancer. Its biology is aggressive, and it's fast moving. So the chance, the window of opportunity for screening is shorter there. And we really need to do a lot more research in determining which type of people generally have which type of tumor, so that we can adjust our screening and maybe screen more frequently the people that have these higher or these more biologically aggressive tumors.
Who are the patients that should be screened?
Well, we screen 2 groups of people. The first is women who are over the age of 50, because that's when the incidence or frequency of ovarian cancer increases markedly. But the second group is people, women who have a relative that has ovarian cancer. Also women that have a relative that have breast cancer, a little bit more likely to have it. So, but in our screening program, it's women over the age of 25 who have a documented family history of ovarian cancer in a primary degree relative or a secondary degree relative, and also all women over the age of 50.
Okay. So what we're looking at now, this is a picture of the equipment that you use in order to screen your patients?
Yes, this is exactly. This is transvaginal sonography. And in this particular machine, through sound waves, generates a very accurate picture of the ovaries. And we do this through a transducer, a very small transducer that you can see on the right there, that's placed intravaginally, very painless. We've screened well over 35,000 women for an average of 6 times. We have well over 150,000 screening years, and we've almost never had a complaint about this procedure. It's very quick. It takes us about 5 minutes to do. It's painless generally.
Now, let's look at what you're seeing when you do these ultrasounds. So in this picture, we're seeing what?
Well, in this picture, we're seeing the dark area is a cyst. It's an ovarian, it's a cystic ovarian tumor. And if you were to do a pelvic examination and feel this, you would think, well, my goodness, this is a big tumor in the pelvis. We would be worried about it. But we know from the studies that we've done is that this is mainly a cystic ovarian tumor. You see The dark area there is the cyst. It usually contains fluid. And there are no solid areas in this tumor or papillary projections. So we've operated on a number of people with these type of tumors. They're always benign. We followed a number of women for an average of about 6,000 patient screening years for follow-up years, and these patients never have ovarian cancer.
So this is something you don't have to worry about?
That's right, and as a matter of fact, about 60% of these tumors disappear on their own.
Now, how does that differ from what we're seeing on this next picture?
Well, this next picture is another sort of variant of that. It's called a septated ovarian cystic tumor, and you can see that very thin septa there.
Yes,
and it's pretty common, but we've also found, and we've just published our results this year, that these tumors also are benign.
Okay.
And so that's good. When we've learned a lot by having screened so many women and followed them for so long. And we've learned not only that some of these morphologic patterns or the way these tumors look are very high risk for cancer, but we've also seen these patterns, these two that we just showed today, that are very low risk. These patients really never do have ovarian cancer. So in many of these patients, particularly those that are asymptomatic, we'll follow these every 6 months to a year with sonography, and they don't have to have surgery.
Now, compare that to, I guess, what you're looking for or you hope you're not finding.
Yes, and that's in this slide, this next one, you can see kind of looks almost like a growth or a tree into this cyst.
Yeah.
And that is the cancer right there where as the arrow shows it. It's this papillary growth, and when we see that, we know right away that patient needs to have surgery.
Now, that's not going to be confused as something benign or non-cancerous lesions?
Not with us, and not generally. I mean, I think that there's enough literature establishing for physicians, when they see that, they know right away that's a patient that needs to be sent to an oncologist.
Now, when we talk about cancers, either early, middle, or late, or advanced, but you're staging now, of course.
We do.
So how often do you find cancers that are early on?
All right. Now, that's a very interesting question, because without screening, 3/4 of women present with stage 3 or 4 disease there's 4 stages of ovarian cancer. The higher you go in the stage, the more advanced it is.
So what does stage 3 mean?
Stage 3 means that it is spread intra-abdominally beyond the ovary. And so it's not confined to the ovary anymore. It is spread, these ovarian cancer cells are actually in upper abdominal organs, such as the omentum is commonly, or the diaphragm. And so by the time women come in and say, if 3/4 of them have advanced disease when they come in, they have these tumor cells that are spread throughout the abdomen. Very different than stage 1 disease, which is confined to the ovary.
So when we talk about the chances of survival, curing a person, what's the difference between someone coming in with a stage 1 cancer confined to the ovary or stage 3 when the horse is out of the barn?
All right. Now, if it's confined to the ovary, the 5-year survival rates with existing treatment, not future treatment, existing treatment, 90%.
Wow.
Survival rate. On the other hand, stage 3C ovarian cancer, which is the most common stage that women present with, the 5-year survival is only 30%, and 2/3 of those patients that are surviving at 5 years actually have persistent disease and will ultimately die. So the cure rate, the absolute cure rate of patients with stage 3C disease is more like 10%. So 90% with stage 1 disease, 10% cure rate with stage 3C or 4 disease.
That's a huge, huge difference. What is the stumbling block to people getting screened for ovarian cancer?
Well, what we're trying to do is pick out a needle out of a haystack, and and we started ovarian cancer screening. We were the first university to do this in this country, we started our ovarian cancer screening program in 1987, and we have continued to the present time. And really, what we're trying to do is make sure that we identify patients. The goals of screening are specifically, as you have alluded to detect these patients with ovarian cancer at a stage, an early stage, when they are curable. And we also, because it's screening and we identify certain tumors that a patient is totally asymptomatic, they didn't know anything was wrong with them, they go in for screening, and we find something that's benign, we want to make sure that we know that person has a benign tumor and may not need surgery, so that we're not doing, quote, unnecessary surgical procedures. So we want our screening to be very sensitive. That means if the patient has ovarian cancer, we want the test to pick it up, and we want it also to be specific. We want, when the test says you've got cancer, we want the patient actually to have it, so that we don't have false negatives or false positives. We want screening to be accurate. And so the goals of a screening program are pretty simple. That if the screen is effective, it's got to be cost effective, it's got to be well tolerated by the patient, and it's got to produce a lowering of stage at detection and an increase in case-specific survival. And what that means is patients whose ovarian cancers were detected by screening have got to do better.
And are they?
And they are. And as a matter of fact, in our screening program, we've screened over 37,000 women, free screening. We've detected about 515 ovarian tumors, and of those tumors, 63 are invasive cancers. And of the 63, 75% are in stage 1 or 2. And so we've turned the tables, if you will. And the overall survival of women nationally that have ovarian cancer, all stages, is 40%. The survival rate of women in our ovarian cancer screening program at the University of Kentucky is 92% at 2 years and about 87% at 5 years. So you can see this screening almost has doubled survival rate.
Well, Jack, I want to thank you very much for being with us. You know, you oftentimes think that if somebody's about to cross the street and a bus is coming down, I want someone to stop me before I get out there into the middle of the street. Clearly, by doing screening for ovarian cancer, you have turned the tide on a disease which almost uniformly was fatal for the individual developing, to finding something early enough where we can treat a person where they can be cured. So it's no longer a disease to be feared, but just another condition that needs to be managed. I'm sure there'll be lots of questions, and if you want to get information about getting screened for ovarian cancer, talk to your primary doctor, or feel free to contact the Division of Gynecological Oncology at the University of Kentucky down at the Marquet Cancer Center. I'm sure they'll be more than happy to provide any information that you would require and or need. And please, women, if you have a family history of ovarian cancer, get screened. If you have a family history of breast cancer, get screened. And if there's a strong family history of colon cancer, again, you also want to make sure you get screened. I'd like to thank you very much for being with us today. Jack, thank you for such an enlightening show. And if you have any questions, feel free to contact us at KentuckyHealth@insightbb.com. I'm Dr. Tuckson. Thank you very much.